we know, Cabazitaxel and Lutetium-177 have been approved for patients with mCRPC who had a progression on ARPIs and docetaxel. Actually, Cabazitaxel has been approved in this setting for over 8 years now, and Lutetium-177 has been approved since 2022 for patients with mCRPC and with PSMA-positive disease. Regarding comparing these two regimens, there is this recent phase 2 trial. It's actually a randomized trial, namely therapy trial. It compared Cabazitaxel and lutetium in patients with mCRPC with PSMA-positive disease. And the trial results showed that patients treated with lutetium had better outcomes regarding PSA responses and progression-free survival. However, overall survival data did not show any significant difference between these two regimens. So these are the trial results that we had, but the real-world data comparing these two regimens in this setting have been very limited. So we wanted to assess the real-world outcomes with these two agents in our study. So in our data analysis, we included patients with mCRPC who had a progression on ARPIs and docetaxel, and overall we had 1,445 patients, and our results showed that patients treated with lutetium had better outcomes for both real-world time to next therapy, or TTNT, and for real-world overall survival. Specifically, patients treated with lutetium had a better TTNT with 8.3 months compared to 4.7 months with Cabazitaxel. Regarding overall survival, patients treated with lutetium again had a better overall survival with 10.3 months compared to 8.8 months with Cabazitaxel. So in our data set, we were not able to assess PSA responses or progression-free survival, but real-world TTNT is a good proxy to assess these responses. So real-world TTNT reflects how long patients are able to stay on a therapy in real-world conditions. Overall, our results suggest that Lutetium-177 may offer a more durable disease control compared to Cabazitaxel in this setting. In our analysis, we did this comprehensive propensity score matching to balance differences between two patient groups. However, we did not specifically analyze subgroups like visceral metastases or ECOG performance status. However, from current literature and clinical experience, we know that some patient characteristics could guide treatment selection. For example, patients treated with Lutetium-177 with high PSMA PET-CT expression could have better outcomes compared to patients with lower PSMA expression. On the other hand, Cabazitaxel remains a good option for patients with rapidly progressing disease with high volume metastases and patients with low PSMA expression. So we did not assess the differences between these subgroups, but we believe that real-world data assessing these differences between patient groups will guide treatment selection better in the future studies. And we are currently working on the manuscript to assess these subgroup analyses. That's a great question. That's a very important point to guide treatment selection between these two patient groups. Unfortunately, our dataset did not include safety profiles, so we were not able to compare toxicity profiles between these two patient groups. As we know from current literature and clinical experience, Lutetium-177 is associated with dry mouth because of PSMA expression in salivary glands, and also it can suppress bone marrow. And Cabazitaxel mainly causes hematologic toxicities like neutropenia. Even though we did not assess safety profiles between these two regimens, Our data analysis showed that patients treated with Lutetium-177 had a longer time to next therapy. So this can reflect efficacy and also better tolerability for older patients with comorbid diseases. Our findings suggest that Lutetium-177 could be a better option for selected patients. For example, patients with PSMA-positive disease, Lutetium should be selected. And having said that, Cabazitaxel remains an important option, for example, for patients with rapidly progressing disease or low PSMA expression, or patients who cannot access Lutetium-177 due to insurance coverage or availability. Ultimately, we believe that treatment sequencing should be personalized. It should be guided by imaging results, toxicity history, and patient preference.